Welcome everyone to the Baxter site in Lund, Sweden. It's 9 o'clock here where we are, and you will have a pee break in 1 hour and 15 minutes. I'm Marianne Larsson, and I would like to welcome you to this Innovation Summit in collaboration Baxter and Innovation Skåne on the topic Finding Disruptive Technologies for Treating Patients with Chronic Diseases at Home. I'm Marianne. I work at Innovation Skåne. We drive innovation in health, food, transportation, materials, and lighting. Before walking you through the agenda, I will make a quick tour in a mental helicopter. Global health has improved across the globe, obviously, tremendously over the last decades. However, other circumstances like elderly population, growing populations, increase chronic diseases and reduce access to healthcare. Even in countries like Sweden, ranked as one of the healthiest countries in the world, government-funded healthcare for everyone, people wait for months to get treated. But here's the light. Digitalization, and we call it health tech, empowers the individual being the patient or the profession. This completely transforms healthcare, the whole healthcare system. And let me give you an example. If I have a heart condition, I would happily use the Koala heart monitor, updating me on my heart condition in less than 1 minute, just by pressing it to my chest and to my thumbs, and alerting specialists should I need it. And here's LifePod, sorting patients, thousands of patients, into those who are in need when they need it, as opposed to the regular 6-month visit or the emergency ambulance. The third picture is Optilog, specifically designed to be easy to use for elderly people, highly appreciated. Optilog and LifePod are very popular here in Skåne. LifePod is now being implemented across Skåne for a variety of chronic diseases. They reduce and have proved to reduce hospitalization for heart failure patients by 50%. These are just a few examples of the health tech Nordic community. It's more than 200 startup solutions, most of which are already available and in operation on the market. Innovation Skåne started in 2014 together with other Nordic partners, the Health Tech Nordic. It's cross-fertilization. Health tech is the combination of life sciences and tech, mobile tech, Internet of Things. And right here, you find everything to provide this shift in healthcare and improve health across the world. Here, you find one of the 2 global centers for mobile technology or Internet of Things. The other one is in South Korea. Bluetooth was born here. Ericsson and Huawei both have their global centers for research around 5G right here. Thousands and thousands of people in this region work on everything it takes to make Internet of Things. Design, everything from design on silicon to user design via sensors, radio technology, artificial intelligence, cloud computing, and what have you. And the epicenter for all of this is approximately 500 meters down the road from this very Baxter site. There's also a thriving gaming industry in this area that brings new value to health tech too. The new European spallation source is being built right here in Lund, bringing new visibility to very small things. As nanotechnology, which is another expert field in this region. And now onto the life science scene. Of course, Baxter, embracing the Gambro artificial kidney invented here many years ago, and other examples of strong life science institutions available in this region. The Koala Heart Monitor and LifePod were both built here, along with another 60 or so HealthTech Nordic members. We also know that tech is getting cheaper and cheaper, affordable to everyone. Once that people have food on the table and shelter, families usually get themselves a mobile phone. I'm looking forward to a world with healthier lives for everyone. Today, we're going to talk about new possibilities and advanced healthcare at home. It will call for new solutions designed for users with limited training, designed for new environments. And here to welcome you all, setting the scene from the Baxter perspective, let me introduce Per-Ola Victor, Director, Ph.D. Therapy and Water, and also the site manager here in Lund. Welcome, Per-Ola.
Thank you, Marianne. So today, we are going to experience the Innovation Summit that we have planned for today, together with Marianne and Innovation Skåne. This is a specific event for us. It's very important for us. We have been pioneering dialysis for over 50 years. Lund has been a major part of that. And looking forward for the next 50 years, we will be pioneers in other ways, not in the same way. We expect that we, together with many, many partners around the world, will drive the solutions for the renal society. So for this reason, it's an important day for us. It will set the scene, and I hope you all will get inspired by this day. So welcome to all the presenters, and thank you for me, and enjoy the day. Welcome, Hans.
All right, let me see if the clicker works. I want another picture. I will give you an overview of the day and some instructions. We will have 8 presentations streamed in 4 different blocks. The first block about dialysis at home. 8 presentations, each speaker has 15 minutes in total. And they're prepared to talk for 10 minutes, and then questions and answers for 5 minutes. I will get back to how you do that. Questions and interacting on these sessions is done using Pigeonhole via your mobile phone. So please pick up your mobile phone. I want the next slide, please. Yes, do you see the QR code? You can use that with your mobile phone, scanning the QR code, or entering the website pigeonhole.at plus the code in this slide. I'll give you a second to do that. Here you can write questions. You can look at other people's questions. You can vote for the questions that you appreciate the most and you want the speaker to address. I hope you have found your Pigeonhole on your mobile phone, and stay on this viewer, Vimeo, to see the speeches. So back to the agenda. Presentations are divided in 2 blocks, with a short break in between. After presentations, there will be interactive discussions, more information after the 8 presentations. Starting now on the theme home dialysis, I'd like to invite Anders Christensson. Anders Christensson is a professor of Lund University, a head physician at the Department of Nephrology, Skåne University Hospital. And he's made some groundbreaking work in empowering the patient at home. Welcome, Anders.
Thank you very much. This will be a very exciting day to see all new things happening. I will talk about a way to increase home treatments and by using digital solutions that we have developed here at Lund University and Skåne University Hospital. As you all know, chronic kidney disease is quite common in the population, but luckily only a few patients progress to the end stage renal disease stage. And as all organs, also the kidneys age, and you get a decrease in the renal function by age. But if you have a disease affecting the kidneys, the renal function decreases faster. And when you reach below 10%, then it's time for dialysis or transplantation. Dialysis can be performed in two ways, either hemodialysis, where you use an extracorporeal circulation and you filter the blood outside the patient, or you can use a method called peritoneal dialysis, where you use the peritoneal membrane as a filter, and you use fluid, 2 liters, that you put into the abdominal cavity, and after a few hours you can remove the fluid with uremic toxins. Both of these methods can be performed at home. Hemodialysis at home is a quite complicated treatment that only a few patients can do, but peritoneal dialysis is easier to perform and more safe to perform at home. So that's the first method you usually choose for home treatments. There are some requirements if you want a good result. You need a well-informed and trained patient. You need to communicate with the patient at home, and you need a simple and safe equipment. So in modern healthcare, we have goals, and one of the goals is to increase the number of patients with home treatments, and this is very important in the renal care area. We also need safer and more simple treatments, and we also want to improve the patient outcome by using home treatments, and that is a better blood pressure regulation, improved compliance, and a longer survival for both the patient and the method of use at home. Just a few years ago, Ph.D. was quite primitive. We used paper documentation. It seems quite old-fashioned today, but actually that is used very often. And the patient performed the dialysis at home and documented on a paper. So we decided to set up a more modern way with distance monitoring of home dialysis, peritoneal dialysis. We started a collaboration between Lund University, Skåne University Hospital, and Region Skåne. And we wanted more online information from the patient at home to the hospital. So by sending the blood pressure and weight into the hospital and also the ultrafiltration volume, we get a very convenient way of following the patient at home. As you can see on the picture down to the right, there is a depiction of blood pressure, weight, and the vertical lines are the ultrafiltration volume. So each day the nurses and doctors can follow the patient at home, and also the patient get the same view. So this made it much more simple. Of course, we communicate with the patient, but from before using the phone, we have more used the chat function or camera devices and different ways of communicating. Well, what are our experiences then? Well, now we have close to 100 patients in Skåne on distance monitoring of Ph.D. at home. We have increased the number of patients with home treatments, which is one of our goals. And it's safer and more simple. We have also increased the support to the patient by giving a better visualization of the treatment, and also an easier way of communicating. That has been very appreciated. We have other experiences too, and that is, in the beginning we had a lot of critics, of course, and many colleagues said that this would get the contact with the patient would be harmed and not that good. But actually, we have experienced the opposite with a very closer contact with the patients. And the patients, many say that it feels as in real life when you meet your nurse or doctor. So the patients are overall very positive to this. And also my physician colleagues are getting more into this concept and accept it. So it takes some time to change your way of working. We also have learned more about our patients. We get a closer communication and more frequent communication. And as I said, the patients feel more safe and comfortable. So what are the challenges? Well, that is, you always have to create a comfortable situation for the patient. And you also have to take into account health literacy, that some patients haven't got maybe the ability to adapt to new technical inventions, and then you have to support with more training and support. So that's a very important task for the healthcare workers to know about this. Yes.
I'm very sorry to be interrupting here, but obviously we got some streaming difficulties on the Vimeo channel. On that channel, you also see, on that channel, in the description, you see a YouTube link. It's much better on YouTube. So if you have problems on the Vimeo channel, go to the YouTube channel described below your Vimeo image. Okay. Thank you so much.
Okay, thanks. I hope you can follow it. Among the challenges, you also need to, you have to have a very good way of communicating, and also it's important to visualize the treatments at home, both for the healthcare workers and for the patient. And you, as I said, you need a good support to the patient. But one barrier is your colleagues at hospital. You need to actually convince them about this and try to show it very often, and then after a while you get them on the way to use this. And now most of my colleagues are very pleased to use this way of driving home treatments. So our goal for the future with the renal healthcare in Skåne is to transform it from in-hospital treatments to more home treatments. And by doing that, you need digital solutions, and this was one way of improving this transformation. Thank you very much.
Thank you, Anders. Now we don't have any questions from the audience, I would like you to elaborate a bit more about your vision of this.
Well, as I said, the vision and the goal is to let more people have this ability to have a treatment at home.
Did I hear all people?
Well, if you could, all people, but you have to be realistic. So we take it in steps.
In steps.
In steps, yes. But we want actually, when you start a procedure like this, you see that it's very easy to. The patients are very positive.
Yeah.
It's very easy to get patients interested in home treatment and using modern technology.
Was that a surprise to you?
Both yes and no. I thought it would be more difficult to convincing the patients, but that was very easy. It's more difficult to convince my colleagues, actually.
And what made them change their minds about this?
My colleagues?
Really, yeah.
I think they saw the possibilities, and also they listened to the patients who were very positive. That was maybe the driving force, I think.
And now you're taking the next step for more advanced care at home.
Actually, we want to use this technology also for home hemodialysis. And you can use similar technologies for different things. We're also very interested in prevention of diseases, so that you don't. Well, we want to prevent getting the end stage disease stages.
And how can that be done?
Well, you can improve blood pressure treatments and the blood pressure measurements at home. So that's our next goal.
So by keeping my blood pressure low, I reduce the risk of these kind of internal diseases?
Yes, then
that
you
so?
decrease the risk.
Okay.
So it's very important with a good blood pressure
Good
regulation.
Blood pressure, all of you. Blood pressure measurement can be done at home too.
Yeah.
Okay. Let's see if we got any more questions regarding your speech. So I get this question. Did I understand correctly that 10% of adults have CKD without knowing? Is there a way for these people to find out?
Yes. Actually, this is a silent disease, and a lot of people don't know about it. So it's very important for the primary care to diagnose the chronic kidney disease early, because then you also have a possibility to prevent the late stages. So that's one of the main goals for the whole healthcare system.
But then you need to go to visit the primary care to get the diagnosis.
Yes. To get the diagnosis, you have to go to the primary
But if I'm not aware of this issue?
Maybe you buy a blood pressure device at home. Then, if you have a high blood pressure, then it might be a renal disease. Of course, it could be another disease. But in the future, a lot of people, they are so interested in their health. So a lot of people, they buy their devices already.
They do. And they're getting cheaper and cheaper.
Yes.
Okay. What is health literacy like today in healthcare? And how good or bad is it working out?
Actually, this is maybe one of the more important questions. Today, a lot of people, they are very digital, and they have a lot of technical devices. So the problem is less today than 10 years ago, but still we have to account for it. Older people and people maybe less educated and with language barriers and things like that, that's a very important question for the healthcare system to account for, so that you know that the patient can handle the treatment. So that the training of the patient, and you have to know your patient before you start it.
And we got another question here. to identify CKD early, it's a good idea. Is it a good idea to include 24/7 urine analysis in routine health check for diabetes patients?
Absolutely. It's very important. It's very easy to diagnose. It's a urine sample. It's a simple blood sample and also blood pressure measurement. Then you can diagnose a lot of these diseases early, very early.
Very good. Any more questions? Your reflections on the questions you got so far. Any other questions you usually get that we missed?
Actually, if I would give an advice to people starting this, that is to inform your colleagues and show your goals and your vision. You must have a vision. Then it's much easier to get the whole team into it. But actually, it was easier than I thought.
Yeah.
So don't give up.
But talking doesn't do the trick, does it?
No, it's the start. But actually, it's very easy to show this. The technology is not very advanced. It's more the concept that you use. So it's quite easy to start this journey into the digital way and distance monitoring.
I would ask, could you offer your pictures to the audience? Would that be possible?
Yes,
I mean,
of course. Yes.
Conveying the message, showing happy patients at home doing this in a new way.
Yes, of course.
And perhaps some concrete results from that?
Yes, we can do that.
That's very good. Another question popped in. Is it possible to add health literacy questionnaire in the digital solutions to find out?
There are some centers in the world trying to do that, and I think that would be a good way to find out more about the ability of the patient to do more advanced treatments at home. So it's very important. I think there will be a development in that area, a very strong development.
Next question, and now I identify the people who post the questions. I'm sorry not to have done that before. Roger asks, what would it require to put more patients on PD instead of HD treatment?
Actually, our goal at our hospital is PD first, because we know it's very good in the beginning of the dialysis era of the patient. And also, by introducing a new technology, then it gets a very high status, PD versus hemodialysis. So I think by improving the PD management at home, that's also a way to get more patients on PD instead of hemodialysis.
Okay.
So this is one way of get success in that.
Thank you very much, Anders. There's more opportunity later after these speeches to discuss with Anders on the theme dialysis at home. Home dialysis is that topic theme later on today. Thank you so much,
Thank
Anders.
you very much.
Now I would like to introduce Thomas Hertz. Thomas, you're the director of Renal Innovations, to shorten it slightly. Yes. Thomas has been into innovation in Baxter for more than 25 years. He's passionately engaged in needs of both patients and profession. Welcome, Thomas.
Thank you very much. I will then talk for the Baxter side of it, meaning we are a product provider. We will serve patients around the world. And that's our starting point. We have to cover all those patients, help them to the best of our abilities. And that also means helping the healthcare professionals provide the therapy to those patients. And now I need some slides, I think. There we go. Thank you. So the challenge that we see globally is the increase of patients over time. And the graph you see here is from 1990 to 2022. Patients have gone from 500,000 to roughly 5 million in that time. And that exceeds widely the growth of the population of the planet. So we see a rapid increase in patients requiring some sort of renal therapy, and that falls then into the categories transplantation, hemodialysis, and peritoneal dialysis, as Anders talked about. And this is not stopping. It keeps growing at a rate of 6% each year. That obviously puts an enormous strain on the healthcare budget for each country or each individual in those countries where it's not supported by the government. And this is compounded by that our population is getting older, meaning that they have more comorbidities, other diseases, and requires, in general, more and more care. So how do we manage that? Well, Anders is perfectly on track. We need to go for more home therapies. There's no doubt about that. And the question is how we do it. And that's where we are looking ahead and trying to identify how to do it. So this is sort of the ideal picture of what automated peritoneal dialysis could look like in the home of patients. You see the cycler sitting next to the patient in the bed, and they're very peacefully lying there, reading their books before going to sleep. Now, the reality is slightly different. This is a real-world patient in their home with all the boxes that is required to perform this dialysis. They do a lot of labor to be able to perform this therapy. And that's something we should not forget. We should try to help with that as much as possible. The alternative is home hemo. Home hemo means putting a big machine next to your bed, rebuild the whole home more or less to provide water to that machine. You have the water purification device in the rightmost picture in a cabinet, and then you have to store all the disposables, which also is pretty big volume. So in this case, this home hemo patient here in Skåne essentially had one room as his hospital room, and then the rest of his apartment was his normal life. And he had to split those to make it happen. So what are the challenges we see? Well, number one is the patient burden. And patient burden is huge. They take care of all the work that they usually get as a service in the dialysis clinic in the hospital. And that's a big difference. And you have to convince patients to be willing to do this. So it falls down in a number of categories where we think we can help and will try to help. Number one is the technical complexity of actually performing the dialysis. How do I connect those tubes? How do I make this aseptic so I don't get infections? How do I punch the buttons on the machine? And we know that older patients tend to lose their ability to learn new things, and therefore it's very difficult for some patients to learn how to operate those things and do it correctly. That translates into that you need to have the confidence to do this, so that you actually do it well and not being scared of it doing something wrong all the time. And the third one is you need engagement. You need to really care for your disease 24/7, all the time, and there's limited support if you do this at home. Like Anders told you, in the paper-based world, you had feedback maybe once a month when you went to the hospital with your records. And that's a month when you're on your own. On top of that, you have to take care of the rest of the diseases, what I call care management, meaning make sure you take your drugs on the right time. And then you lose the social interaction because you spend so much time caring for your disease that you're to some extent locked into your home in the worst case scenario. And that, all of this leads to a burnout where patients just give up. They say, I can't do this anymore. And they either revert to in-hospital care or they give up and say, we withdraw from therapy, which means death within a certain time. All of this, we have to support the patient to do better. And that's a big challenge, number one. Challenge number two that we see is the need for healthcare professionals to care for more patients. We did talk about the patient growth. You see the graph again on the left side. And you see the growth in nephrologists and clinics is nowhere near as big as the growth in patients. So there's a gap. And how do we help that? The graph on the right side shows the number of nephrologists per 1,000 end-stage kidney disease patients, and it varies widely over the world. Italy has the highest numbers. Each nephrologist essentially cares for 10 patients there. Then it goes down. Sweden is somewhere around 22 nephrologists per 1,000 patients. Malawi, country in Africa, 19 million people, 1 nephrologist. And that nephrologist happened to be a Finnish doctor who was about to return home. So it's a big difference. How do we help doctors, nurses to provide care for so many more patients in the world without getting burned out themselves? Third, it's lots of fluids and disposables that we have to send to the patient's home. For peritoneal dialysis, it's roughly 3,000 liters of fluids plus 300 line sets and some disposables that you have to bring into the home every year. And yes, it's being delivered to your door, but inside your home, you got to carry it. And remember, these are older patients, maybe small little ladies. It's not easy. So we have the challenges around logistics. You have to have space for this at home. Then you have to care for the waste. That's extra waste that goes into your waste bin. And naturally, we have to think of the environmental impact because these are a lot of plastics as well. So these are the big three challenges we see. And we would certainly like to have a nice collaboration and for good ideas how to solve these. I'd like to briefly mention two things we do to help. We are working on a project where we are producing the fluids in the home. And that's primarily to address challenge number 3, to avoid having lots and lots of fluids that has to be transported and stored in the home. And we do that by a water purification device which takes tap water, purifies it, and then mixes it with concentrates, and we make the dialysate locally in the home. This brings the benefit. You can see the number of boxes that you need for 1 month there, brings it down significantly. And we think this has clear benefits for the users as well as for the environment. Next, we are doing a similar thing as Anders talked about, connecting the patient to the healthcare professional or to the clinic. And we have a software called ShareSource that does this. It talks to the automated peritoneal dialysis machines, which then sends data through the cloud to the clinic, but also to Baxter, so that we can provide, for example, technical service when needed. The machines can say, we need something fixed here, and we can send a service guy to do it. But in general, the most important thing is that treatment data is being sent directly to the clinic so that they can review that and see what they can do about it. And given that we have to care for more and more patients, we have set up a software which flags the patients that you need to care about. So in this list of treatments, you will see green for all the treatments that's gone well, but there's also treatments that need some attention. And the doctor can see this very quickly and then see what they need to do to help the patient. So that's where I would leave it. We are very happy to invite for collaborations where we can solve for these challenges. The patient burden, I think, is number one. That's clear. Number two is how do we support the doctors and the nurses to provide care to more patients? And finally, how do we reduce the fluids and disposables volume in general? And you see the emails at the bottom if you want contacts for us. Thank you.
Thank you very much, Thomas. We have some questions here from Filippa Göransson concerning the global challenge of disease. Instead of increased disease rate, what would need to be changed in society and politics to make disease decrease instead?
That's a beautiful question because prevention is obviously much, much more effective.
Yeah.
We would love to see that because it's not sustainable to have the growth. So prevention is super important, and we see that happening in the developed worlds. I need to check with Anders, but I think the number of dialysis patients in Sweden is pretty much flat, whereas the rest of the world is growing. So it's partially good prevention, it's partially the big diseases like obesity and diabetes, but substantial portion of the growth is also in the developing countries where there's no money for the patients, and as they become richer, more and more patients do get care, and that's part of the growth. So I think we have a chance to flatten the curve, but it will grow significantly in the developing countries because of simply them becoming more rich and can afford the care.
So the growth you showed was known cases?
That's the cases we have right now as end-stage kidney disease cases. It's not the chronic kidney disease cases, which are the big mass of patients who have gradually decreasing function in their kidneys, heading towards dialysis unless it can be stopped.
But the statistics you showed was those that we have statistics on.
Yes.
So there might also be a number of people out there dying from the disease without knowing that they have it.
Absolutely.
Okay.
A number of years back, like 5 or 10 years ago, there were 200,000 dialysis patients in China, whereas based on the population number, you would expect 2 million.
Yeah. So another question from Filippa. Sweden does not have a folkhälsolag. Can it, legal authorities on the prevention side, I would guess. Can it be innovated with Innovation Skåne to cover challenges in a holistic manner? Dreaming of the future.
So the challenge, absolutely, would be wonderful. Can we force people to take care of themselves and take preventive measures? I doubt it, frankly. We will always see people who say, I don't care. So I would say in the modern society, you need to nudge people more in the right direction, trying to make them live healthy lives. And you need to start early because these diseases take a long time to develop.
Yeah. It may sound surprising to many, but that's where the gaming industry comes in.
Absolutely.
We have several solutions that actually affect behavior in diabetics, for instance, in developing diabetes. Yeah, I think that's about the questions we had. Thank you so much, Thomas, and you will also be available later today for discussions. So keep phrasing your questions on this theme. of home dialysis. Now we're entering the next theme for today, and that is home care data, with 2 sessions, starting with Charlotte Castor. Please welcome up on stage. Charlotte is a pediatric nurse, a Ph.D. and researcher at Lund University. She has 25 years of experience from clinical work as a pediatric nurse at Skåne University Hospital. Research interest is mainly in child and family-centered care, pediatric palliative care. Welcome.
Thank you very much. And thank you for inviting me to talk about this important issue of future care, namely home care services for children. And I'm waiting for my first slide to appear. But the reason I want to talk about home care services for children is partly because it's still limited within Sweden and also internationally. And when it's available, it's not always adjusted and optimized for children. So why then is it important that we increase the possibility for home care? Well, first of all, it's the child's right, as stated in several policy documents, both in Sweden and internationally, that children should only be provided care in the hospital when it cannot be provided anywhere else. And that's because we know that home care have the potential to minimize all of those negative impact that hospitalization can give to a child and its family. And this is my research as well as others. We know that home care gives the possibility to maintain a kind of normality or even increase the normality of family life. And we know that it can increase the health of both the child and the family members. And also it helps strengthen the child's possibility to participate in its own care in terms of being active in decision making and so on. So altogether it decreases the impact of illness on the child's life. So before I elaborate a little bit more about that, I just want to highlight that when we talk about home care services, it's a huge variety of services in there, and we've already heard about some of the devices available. But I'd like to stress that in the end of that spectra, there's the healthcare service where healthcare professionals provide care within the home of the children. So healthcare professionals do the care, they provide it just as they would have done in the hospital, only they carry it out in the child's home instead. And then in the other end of the spectrum, there's all kinds of facilitation and support and devices for that and mechanisms for that, for example, e-health, that support families in doing the care themselves to a higher degree. So if we go back to the focus of my talk is the home care provided by healthcare professionals, and that was also the focus of my PhD studies. And we performed that study here in Skåne in the setting of palliative care and advanced home care services, and I will maybe refer to that as ASIH later in the talk. And that is kind of a supplement to hospital care, where healthcare professionals provide care for children in all ages with different kinds of illness and in various stages of illness. And they might give a small, very specified task, like antibiotics, or they might give a more comprehensive end-of-life care, palliative care in the home. And we found out that this can be done to a high level of security and safety for the patients. And this is a busy slide, but I want to just point out some of the statements made of family members, we performed an interview study with families with experience of home care service. And the first is a teenager. He was prescribed antibiotics 3 times a day for several weeks and had to go back and forth from the hospital to the home. And it was exhausting to go to the hospital all the time. And I told them that I can't do it because I get tired and I haven't got any strength to do anything else. So when he was referred to home care services, he could return to school and even soccer practice while still getting his treatment. The second statement is from a father also pointing out how to maintain a little bit of normality or quality of life, even in a very stretched situation. This is end-of-life care. She was able to have a cat in her bed, and we could all lay down together with them and watch television. Another thing that parents pointed out, there was the possibility for home care to provide a more family-centered and child-centered care. When they saw her in her environment, that is her home, they were also able to see what was important for us. So they could adjust care for this family as they could see them in their environment. And finally, from a sibling, showing how home care made it possible for both the ill child and the siblings to be more active and more partaking in the care. They could decide what to see and when not. So this is a sibling describing that when they came, that is the ASEH, he wanted me and my friends to sit down in the sofa and see how the treatment was given. In other situations, siblings described that they were not even aware of the child receiving care, which was a great privilege for them. They did not have to make changes or prioritizes in their life. They could just go on, and the ill child was given treatment without disruption. So there were a lot of positive effects and positive feelings around this kind of care. However, there are clouds and risks in the horizon, and we need to be aware of those in order to maintain high quality when we transfer care to the home. First of all, we saw that this was given to a very small number of children, although they were heterogeneous and a complex group of children, which puts high demands on competence from the healthcare professionals. We could also see that both professionals and families were talking a lot about trust and the importance of building a trustful relation, and that takes time, and it is also always at the risk of being destroyed again. And then for healthcare professionals, not mainly taking care of children, but mostly of adults, it's obviously both professionally and personally a challenge to care for ill children. And we need to embrace that in order to make a sustainable work environment for those who perform the care. And then, as we've already heard, bringing the care home might increase burden of care on the patient, and in this case, on the parents, as it gives them responsibilities that they will not have to take on at the hospital. So it's obvious that one size, or rather one solution, does not fit all. We need to improvise, we need to be flexible and compromise in order to optimize the care for the specific patient. And maybe we need to be better at combining different ways of providing care. So just as an end point of this talk, I would like to show you a couple of things that are ongoing research on the Department of Health Sciences here in Lund at the moment. We are developing and evaluating and finally implementing a solution for communication between families in the home and healthcare professionals. It's a tablet with various ways of communication, and we are developing it in close collaboration with the technical department, but also with stakeholders, which is the parents in this case, as well as healthcare professionals. So this will be a way of communicating via chat, videos, pictures, but also pre-decided scales and measurements specialized for different kinds of needs in different kinds of pediatric care areas. And then finally we have the phases thermometer scale, which originally was developed in Göteborg University, and now we are validating it in collaboration with them. It's a digital self-assessment symptom management application, to make it difficult to say. But it's an important way of making the children, again, more participating in their own care. They can have an application on their own smartphone, and they can communicate their symptoms to the hospital when they find it fit, wherever they are and whenever it is, which is a great opportunity for increased participation in care. So those were the final slides that I had, and thank you so much for listening.
Thank you very much, Charlotte. Oh, I feel sad about the kids. I'm happy to see that you're working heavily on making the situation better for the kids. We have a question here from Roland Persson. Is there a significant difference in outcome when providing care in the home compared to in the hospital?
Well, that's a complex question with many answers, and I guess the overall answer is that we know too little about it in detail, or in overall figures rather. But in those cases where there have been done studies, it turns out that it seems to be feasible and safe, medically safe, and also most emotionally safe for the patients. But of course, studies are always done within settings where there are extreme circumstances. So it needs to be thought about in every case, I would say. But research does not show any increased risk so far.
Okay. Mm. Another question from Matthew Foury. I'm sorry about the pronunciation. Thomas mentioned that kidney treatment patient growth is flat in Sweden. Do we see a different trend for children?
I'm not the right person to answer anything about kidney diseases, I'm afraid.
We have a lot of people in the studio behind the scenes, and maybe we can have some indication from one of the others. Anders?
Maybe quite flat.
It may be quite flat for children too. Okay. No other questions here. I'm curious, of course, about the e-health solutions that you're trying out.
So are we.
Yeah. So far, what do you see?
Well, we can see that there's an interest both from healthcare professionals, but of course also from the families and within the pediatric department, the generation of people work or treated
Yeah.
are, of course, the right generation to use digital solutions. Parents to our children have been growing up with these solutions around them. So we are fortunate in that way, and they find it so natural to send an SMS only instead of picking up the phone to call.
You do some texting too, don't you?
I do.
Even you being very old.
I do.
Okay,
I do.
thank you so
That's
much.
right.
Thank you. So, well, there is one more question from Roland. Is there a difference in treating children and adults at home?
Yes, there is. There are lots of differences, and we found that out in our research when we interviewed healthcare professionals. That in the feeling of giving care, there's a huge difference. It is so different to approach a child. And there's also the case that you have the child, but you have also parents that you need to relate to, and to find out how are these relationships configured. And that is something we always do in the pediatric department, but it's a bit different when you use to adult care. So there's a huge difference. But when you begin to think about it, there are also huge similarities, and I guess that one of the things that needs to be done is to also show the similarities.
I need to cut this session there, and you will of course also be available later when we talk about home care data. So next up, thank you so much, Charlotte. Next up is online Minna Storm. Minna is the CEO. Hello, Minna. The CEO of Nordic, and I know her as one of the most connected, efficient, and enthusiastic drivers of improved care that I've ever met. Welcome, Minna.
Thank you, Marianne. That was wonderful how you said it. It is a great pleasure to be here and to be able to listen to the presentations before. I really enjoyed it. And actually, I would like to lift up the question that Roland was asking, significant differences when providing care at home compared to any other place. That's I would like to discuss with you today when it comes to the Nordic perspective. My background shortly is not from the healthcare side. I'm not a healthcare professional. My background is in expanding, scaling up Nordic health and Nordic smart care at home. I do ecosystems and work as a spider in the network, basically, and look at the solutions, the care providers, research, as well as the patients and individuals, what is going on in the Nordics at the moment. And therefore, I would like to lift up some questions concerning the Nordic perspective on smart care at home. Let's see what is in my slides. Thank you. We could go to the next one. Yeah. So basically, when we talk about the Nordic perspective, as we've heard already today, Nordic care is already to a high extent technology-enabled care. And we target on personalizing the care, and at the moment, more and more in prevention of the chronic diseases, already what we heard from Anders and what we heard of Thomas and Charlotte. I also think that if we look at the Nordic perspective, we already are very much connected. We use all kinds of apps and devices at the moment, and of course we have a higher number of elderly people. At the moment, by 2050, we're going to be 27 million people in the Nordics. Out of those, every fourth is over 65 years old. And that brings us challenges. And very much nowadays, when we talk about the Nordic smart care at home, we set the focus on the elderly people and people with the chronic diseases living at home. At the same time, I would like to emphasize the entire society, the entire Nordics, from babies to elderly people, all of those, and to see in what way we can bring as much as possible of the care to your home or to an environment where you're spending your everyday life, instead of spending it outside of your everyday context and home. I think that the best thing in the Nordics, one of the best things is that we have huge amount of similarities in 5 countries. That means that we already used to working together. We also have lots of differences. We talk about the differences in our reimbursement system. We talk about the differences in how to handle the care. But that is also a bonus. It's a plus, because that enables us to learn from each other. Next. Do we get the next slide? Do I get the next slide?
So it's the potato slide?
sorry.
That's what we see?
Yeah, sorry, yeah.
Okay.
Yeah. So already at the moment we are more aware, like actually Andreas was saying in the beginning, we are already more aware about our conditions, and we are already buying our devices and manage. We are pursuing a longer and healthier life. And that also gives us a very good ground for talking about the preventive care. I think at the moment, when we look at the Nordic countries and we look at the challenges, we are talking about the huge amount of data, the primary data as well as the secondary data. And we all very much provide this data, which is for making our own care much better. Then we are talking about integration. But at the same time, we already, as individuals, we distribute and accept the sharing of data. We are sharing it to not only to the healthcare, but we are sharing to a number of different sources. So I think that these challenges that we face with data and the integration, we have to be able to tackle the issues in the way that the user-centric perspective is taken into account. In many cases, if you think about a person who is a chronic disease patient living at home, she or he has one target. We around him or her, we have many other targets. We want to do this and that, provide solutions, we want to do other kinds of things, we want to follow, we want to gather the data, we want to provide devices. She or he has only one target. And that, I think, is the leading star in providing smart care at home. As we've heard so far, we've already, the care at home has already come home. If we look at the COVID-19 situation, the number of distance care and monitoring and meeting a doctor at home is exploited. The number of users has already exploded, and even to new target groups and new individuals. We are more and more familiar with using care at home and using all this kind of technology-enabled solutions. At the same time, I really liked what Anders was saying in the beginning. He was saying that it's not all about everything new. I also think that many of the solutions we already have. It's about making the gap between the reality and the technology and the patient preferences and needs to meet. I think it's very much about that. And at the same time, it is the responsibility of the responsibility shift. Very much of the data sharing, the integration, providing something by yourself, it's moving towards an individual. And at the same time, I think that we in the Nordics, we are ready for that. The readiness for moving into providing and taking responsibility is there. Then we have things around us that needs to be developed. Let's take the next one. Yeah. So if we look at, for example, how we understand the care at home in a traditional, in many ways, if we look at the elderly people, if we look at the whole Nordics and we look at the home care providers, for example, the amount of big providers is very, very few, and then we have a large amount of local or regional, they could be public, private, half private care providers is very high. And that I think that this market is going through a very extensive change, because if we talk about smart care at home and home care, that is not only the home care in a traditional way, it is very much to all ages and depending on the individual needs. And so we need to take into account issues such as loneliness, isolation, self-care, and facing the new context of providing care. Let's take the next one. Some of the examples of user-centric smart care, we have lots of great examples in the whole Nordics, and we are in the middle of providing tools for innovations ourselves. Let's look at Denmark. Geritolobus is an excellent example of bringing care to your home. It started with the mothers-to-be and heart failure patients, as well as elderly people, where not only traditional home care was provided, but services and care that you would normally get at the care center or at the hospital was brought to you, and that made it very easy, and especially when it comes to mothers-to-be, their need to stay every now and then, depending on their health, staying at the hospital was taken away, so they could stay at home. Up-to-Luck in Sweden, it's a very good example of setting focus on 75 plus people with the heart failure be able to stay at home and providing data by themselves, people that are not used to smart devices at all. But when Up-to-Luck was educating the patients just to remember one thing, to weight yourself once a day. And that in sense brought followed by interest in what have I been doing yesterday, or what have I been doing today? Have I slept well? What have I been eating? And how much have I had activities around me? Very much not needing to set this on technology, but awakening the interest on your own health at the moment. Predictive from Finland, it is a good example of crunching the data and giving foresight, giving preventive care paths, and where you're basically using the data that you are providing, bringing it back to yourself, bringing it back to care in form of care paths. Let's move on. So all in all, the Nordic perspectives, they pursue agility, information sharing, transparency, and collaboration. I think that the most important thing from my perspective is that we all talk about, like you heard the three presentations before, it is that we talk about how well prepared we are and what are the enabling factors in the Nordics. But at the same time, we need to work more together. We need to have my perspective in pursuing the Nordic perspective in smart care at home is that we need to have really 5 countries working together with projects, with pilots, with test labs, and where private and public actors are taking the risks of probably not coming that far as they wanted in that time as they wanted, but all these trial and errors, they are needed. We have perfect national projects which are driving us onwards. But we need to have, in the Nordic scale, we need to have Nordic projects and pilots and test labs in practice. Next one. And then I will, yeah. So basically, our Nordic strategy in healthcare is very much supporting this. But in practice, my solution and my hope is that actors like Baxter and all the companies that are attending today, as well as the care providers, researchers, as well as the patient organizations and ourselves, we take the courage of bringing us together and working over the country borders together and bringing Nordic solutions into action. I think I'm used my time, so that's fine with me.
Yes, that's
Thank
your
you.
time. Your time is up, Minna. Thank you so much. You will stay on too for the discussions later on this today. We're going on to the next theme of this day, and that is data management systems. And I would like to introduce to you Johan Eltes of Cerner. At Cerner, Johan is responsible for guiding the implementation of Cerner solutions in the Nordic legal and technical ecosystem. This includes supporting Nordic innovators and expanding the value of Cerner open platforms. Johan has a background in software and integration architecture. Before joining Cerner, Johan was responsible for the design of the national architecture, the interoperability standards at Inera. As he's also been involved in governing and supporting large national projects. Johan, welcome to the stage. We don't hear you. Please unmute if that's the issue. Oh, so you have sound, but we don't hear you here. I'm discussing with backstage here. Perhaps you need to restart. Does the audience hear me?
Yes, absolutely.
All right. So, waiting for Johan. He's worth waiting for, I can tell you. Sorry?
Pigeonhole.
The pigeonhole, please phrase questions. We had some questions from Minna earlier about the Nordics. Since there are so many solutions available, what are the hurdles? Why doesn't it happen? Smarter care at home. And in my experience running Nordic Health Tech Nordic, it's practically two things. It's the reimbursement system that was built for other purposes. So was the legislation, was built years ago in another world, another situation. But that is about to change across the Nordics. It takes some time though. I think we have Johan with us right now. Johan?
Yes, do you hear me?
Welcome, Johan. So nice to see you. I leave it all up to you.
Thank you. Sorry for the problems. So, thank you for having me here. So I'm happy to have the opportunity to introduce you to the Cerner ecosystem and how we hope it can be leveraged to support chronic disease management and all the innovation that happens in the Nordics in that space. Next slide, please. I don't see the slide is covered by my video. Is there something you can fix?
Take away your video.
I can move it. Okay.
Yeah, exactly. Okay.
Still doesn't work. See if I can scale it. Let's try anyway. Okay. Yes. So for Cerner, we used to say that openness is an attitude, and we are quite convinced that we cannot do all the innovation ourselves. So we need to be part of an ecosystem where everyone can innovate and ideas can strive. So based on these insights, Cerner has been busy for a number of years to adopt a strategy based on an open ecosystem architecture, which we are now launching in Sweden. Next slide, please. Yep, thank you. So in Cerner Sweden, we are engaging with Innovation Skåne, Region Skåne, to set up a center to support innovation on top of our APIs and our platforms. And we understand that we need to support. The support need to be in several areas. So that would be business strategy, it would be clinical supported, and of course technology and interoperability, which is my area of expertise. Next slide, please. So we see that healthcare needs to evolve in the same way as many other domains already have, where data and functionality is made available through APIs to allow third parties to innovate and add value to services and data in our platforms. Next slide, please. So what is Cerner then? Yeah, we support a number of platforms, and they are grouped in 3 families. CareAware, which is for device integration. And then we have Millennium, which you probably heard of, which is the EMR, the electronic health record system, and basically the enterprise resource planning system for healthcare. And then we have our cloud platform, software as a service platform for preventive care and analytics. So that's our newest addition, which is an intelligence, machine learning, AI platform that operates on patient level as well as on group calculating and reporting on group outcomes. It's an advanced platform that is independent of Millennium, can be used by any EMR and any data source, and it normalizes data and makes it available in fairly advanced fashion for planning of care, measuring gaps in care for individual patients, and is a powerful instrument within primary care. We are currently implementing several of the standardiserade vårdförlopp, standardized care pathways, on top of that platform. And all these platforms are supported by APIs, so they are available for innovation. Next slide, please. So what we think is needed to simplify adoption of these APIs is package guidelines for third parties in some prioritized areas. And we plan to package them in the context of the specific legal system, initially for Sweden, and also for specific workflows to make that easy. And there are 2 prioritized domains: chronic disease management and virtual visits. So if you are a third party that has a solution with chronic disease management, which is the target of this presentation, then we are working on providing optimal prerequisites for you to onboard to our solutions through our APIs. And I will show you in a moment what that will look like. So we will do principal workflows that highlights integrations between typical integrations between our solutions or, well, generally health information systems and chronic disease management platforms. And mapping that to standards for exchange that we support through APIs, and also legal mappings. We plan to work out these guidelines in an iterative approach together with you and together with our clients. So please reach out to us and Innovation Skåne to help us package this in a way that is optimal for you. Next slide, please. So to highlight the segmentation that we are doing for these guidelines, so we are looking at different roles in the ecosystem. At the center, we have the ecosystem specifications that I mentioned, and they will be built. They are built on the API standards that we support today, and that's mainly the HL7 FHIR standard, which is a RESTful API standard mapped to clinical context. And we also support clinical coding standards that are used in Sweden, like SNOMED CT. And then there are different roles for parties that are integrating through the ecosystem. So it's the EMR role, that is, for instance, Cerner, but could also be other actors. I listed a few of them there. So Cerner solutions like Millennium, and there are also other actors in Sweden that would act in this role. And then we have analytics, prediction, gaps in care platform role, where we have our health intent solution. I think there's been some mistakes there. So the other ones is cut and paste for that role. But so any EMR role basically could integrate and leverage our analytics and prediction capabilities. And then we have the typical third-party areas that we are working on now. Virtual visit, platform role, and then chronic disease management. And there are also a list of companies that we know are active in these different areas. And we have dialogues with several of these already in various contexts. Next slide, please. So the area, one step back, please. Thank you. The area where we have been most active so far is in virtual visits. So there we have a fairly extensive guidelines today, but we are then working on bringing the chronic disease management forward as well. As soon as we get into collaboration with you around specific use cases there, we will evolve these guidelines as well. Next slide, please. So this is a complex drawing. I'm not about to explain it in any kind of detail. It's more as an illustration of what we put together for you as third-party developers who would like to integrate into our ecosystem. So with these kind of models, we describe the patient workflow, typical workflow for, in this case, a virtual visit platform procedure. And we will do the same for chronic disease management. And of course, there's a huge set of substantial overlap between these two domains. So we foresee to reuse a lot of it. And we describe the clinician workflow, and then we describe the role of the platform, in this case, the virtual visit platform in the green fields, the various capabilities there, and then integrations that happens between the platform and our solutions, which is the lower band there. And then we map that to our API standards, the FHIR standards. Next slide, please. One slide back, please. Thank you. So then you can as a developer, third-party vendor, you can see what FHIR APIs, according to the FHIR standard, that we support for the different workflow steps in the interactions between chronic disease management platform and the electronic health record, like Millennium in this case. Next step, please. So what about chronic disease management and what together? This is the observation we made today, that there are a lot of solutions. You have really nice solutions out there for specific chronic disease areas, and that they are typically deployed as cloud solutions, software as a service offerings. And they are not integrated EMR. So there are redundant work, etc., and data is not get siloed, etc. So what we hope we can do together is to improve the workflows by integrating through our APIs and our ecosystem with our solutions. So the data that you manage is also available in our intelligence platform for holistic preventive care models, etc., but also for the clinician in the electronic health record. Next slide, please. Yeah. So these figures are from the Swedish reference architecture for telemedicine. So you might consult that. It's available at Enera. But generally, we tend to support it, and there are different capabilities that you can support when integrating with us and in the ecosystem. So there's a lot of details here, but that's kind of the level we need to be discussing when we are going to do something in the real life. So it's about exchange of health records. It's about enabling, activating a procedure in your platform from the EMR system to prescribe a treatment, for instance, and then also to track the progression of the treatment by change of observations and questionnaire responses, etc. And also care plans, of course. Next slide, please. So what can we achieve then from an end user perspective when we are collaborating and building on a joint ecosystem? This is an example of a chronic disease management solution as Sellström, diabetes diary, that is embedded into Millennium. So what we see here is the Millennium user interface, and there is a seamless integration of a third-party application in the user interface with full patient context, encounter context, provider context, etc. And it can also be integrated into the Millennium workflows in a fairly advanced way. And that's based on a user interface integration standard called SMART, sometimes called SMART on FHIR. And together with also integrating data flows in the backend through our FHIR APIs, we can really achieve amazing things, which enriches our platform with your innovations. Next slide, please. So this is another example of a view from the same solution. Next slide, please. How to get started with this then? Well, so we have a website for innovators who want to explore our APIs and our ecosystem. So we heavily encourage you to go there. It's code.cerner.com. And there you can see have documentation of APIs and also how you onboard and how you can explore. So there is self-service exploration possibilities with a full-fledged Millennium system backed up by the APIs. So you can try them out, at least in read mode. And then you can go into our onboarding process, which will be explicitly supported through Innovation Skåne together for the Swedish and Nordic market with tailor-made support. in near future. Next slide, please. So once you've onboarded, you're part of a big international ecosystem of solutions that are approved and part of our kind of app store. Well, we don't sell your products, but we advertise them as integrated on our website. All these applications are then certified, so they are. That means that we have been working together to make sure that they make a good citizen for the Millennium user, for instance, and embed well into our workflows.
I'm sorry, I have to cut you there, Johan. You will be available for the discussions later on. We have a question here from Annette Bornegård, which we don't have the time to take right now. We're already 5 minutes over. I'm so sorry. Annette, please, we will maintain that question. You can either join the session later on, or you can email, and I'll give you email addresses later. Thank you, Johan. Now on to, also online, Johan Sellström. We're still on the data management systems session. Hi, Johan.
Hi.
You're a serial entrepreneur and a survivor of the first internet revolution as a co-founder of Icon Media Lab. Currently, you're running 3 startups: Svibe for digital identity, Symbiome for analysis of intestinal flora, and CareChain for health data. Welcome.
Okay, thank you. So if we bring up the slides, please. That's just the introduction. If you want to talk to me, you can email me there. So next, please. So in the previous talk, we heard something about data interoperability. And I think to a large extent, this problem is already solved. We have the format, the syntax, and so on through FHIR standards. We have a grip on the semantics of what a certain statement means in this FHIR standard. And the lacking thing here, though, is the trust. How can we trust the data? Why would I learn all these syntax and semantic standards if I do not trust the data that's being communicated? It's like, why would I learn Chinese or Russian if I only think they're lying all the time? I can't really trust them telling the truth. So if you go to the next slide, I think the trust problem can be broken down. Next slide, please. It's not showing. The trust problem can be broken into 2 domains. One is the identity of whoever is involved in a transaction, in an event that might happen in a health record system or so, and also the long-term data integrity. When did something happen? How do we know it hasn't been manipulated since? And such issues. So if we take the next slide, I think when it comes to identity, we already have systems in place. It's called public key infrastructure, where you have somebody who issues an identity, and normally this is done by government, and so you would have some kind of authority that would delegate down a chain, a certificate chain, and finally it's the police that will issue passports. And you might not know this, but since 2001 and 9/11, we started putting small chips inside the passports. They're similar to the chip you have on your credit card, and they're also using RFID technology or near field communication. So it means that you can read these chips, and they have a unique secret key embedded in them that cannot be taken out of there, and that proves that the passport is authentic. So we have in the world over 1 billion passports like this, and this is like, and in addition, we have national identity cards working exactly the same way. And a little over a year ago, Apple opened up the access for developers to this NFC reading capability. It's already been available on Android for a long time, but that suddenly made it possible to deploy to billions and billions of smartphones a digital identity solution that is provisioned from these e-passports. So if we go to the next slide, you can see what that looks like. So we built an application, and this is the Swipe company then focusing on that. So basically you scan the back of the identity card, and it has a machine readable zone that acts as a password to unlock this chip. So then you put your phone on the passport and it reads the data, and the data is signed and can be verified. Finally, it has biometrics in that card. So the photo you have on the passport, you can extract, and then we do, face recognition to compare that photo to the person trying to provision a new identity. And this whole process takes like 30 seconds, and then you have a really secure digital identity, that's been issued by a government, and it doesn't require anyone, checking your ID like they might do in a bank or something, but you have these digital signatures as proof that it's a real ID. So we use this concept now. If you go to the next slide, we got an assignment from EIT Health to issue certificates that you have been tested for COVID-19. Initially, it was envisioned like some kind of immunity passport. But since then, it's become clear that maybe you're not immune, maybe not everyone has antibodies, and immunity might go away and so on. That, and in addition also the ethical concerns that if it's really essential to have this passport, people might go and infect themselves and die and so on. So it's not really been launched in that manner, but we've still built this system, and we're doing it in Barcelona and the city of Grenoble. Now, when the second wave of infections is happening, they're, however, reconsidering this, that maybe we need some kind of proof of this. And also, once we get into the territory of vaccinations, this is then the ethical concerns go away, because can assume there's no risk of taking this vaccine, and you want to know who has it. So the next slide describes how this works. So you have this app with your digital identity. It's quite similar to Bank ID in Sweden, but it also works peer-to-peer. That's why we have a QR code there, so you can scan it and share your identity with someone in real life, or send links to it. So what happens is that you request a certificate here with your name and your test result, and that is then sent to the hospital or the lab, and they sign this certificate, and it goes into your health passport that you have on your phone, and you can then use that to prove certain things. On the next slide, please. We're also using a blockchain for an audit trail. And this is, you can never use a blockchain for personal data, but you might want to, do it for statistics like the authorities. might want to know when did a certain test happen. You have a timestamp and what was the result and maybe the sex and location or something like that, but not saying who it is. So you put a digital fingerprint, or which is also called a hash, on the blockchain, and you can then use that to verify that. And so both parties involved here, the patient and the issuing organization, they have the data in clear, so they can prove that it's been put on the blockchain by extracting the fingerprint from the data. So it has a proof value in that case. Yeah, so given all that, what we've created then, on the next slide, could be called a health passport. And I call it a passport, not a wallet or something, or a journal or something, but it's truly a passport because given this, that its foundations are from passports, it means that we can get a global acceptance of these kind of proofs. It's not bank ID that only works in Sweden, but it's based on international standards like e-passports. Next slide, please. To make, so what do we need to do to make this happen? I think we need to have a mobile läkarlägg, you know, in Swedish, a doctor's ID that's mobile and lives inside this app. And so we need to issue a doctor certificate, and ideally this should be coordinated by something like the World Health Organization. And just as the issuance of passports that's delegated to the countries, and I think Socialstyrelsen in Sweden would be a good supplier of this to provision, you know, professional accreditation that you're a doctor and you can sign these kind of certificates. And next slide. The thing here is that we're building upon existing infrastructure, and it's only a thin layer on top of that. So it would be very inexpensive to launch this, and I think it would tremendously increase the value of all the health records that we are using. So that is what we built, and in order for you to maybe try it, if you go to the next slide, I just now I put together a little demo of how this works, and it's for voting in the presidential election, you know, for the entire world, and all you need is a passport. So if you click there, you can install the app, and then you can go and vote. As you see, there's only 4 votes or something at the moment. But that gives you an idea of how our digital solution works for this. So that's all I had. If you have questions about technical details, about the blockchains and things like that, I'm happy to take that in the afternoon and have the interactive session.
Yeah. Thank you very much, Johan. We're running over time, but I guess you will be part of you will stay on for the discussion later.
Sure.
Yes, that's very good. So we're switching theme now onto the last theme, monitoring and analytics. And I would like to invite on stage Martin Carlsson, the founder of Accumbo, one of the fastest growing health tech companies in Health Tech Nordic, actually. Martin has a background from Karolinska. He's a specialist doctor in internal medicine, special interests in endocrinology, currently researcher at the Swedish eHealth Institute and the Linnaeus University, and as I said, founder of Accumbo. Very welcome, Martin.
Thank you. Actually, I made my PhD thesis in Lund, in Malmö University, also. So that, and we have an office here in Idén Innovation in Lund, but we have an office also in in Kalmar Science Park. And I'm going to talk about our caregiver, digital caregiver, Accumbo, and how we treat the chronic diseases like the metabolic syndrome and hypertension. Thank you for inviting me. We are, I believe we are the first digital healthcare provider in Sweden for high blood pressure. And we treat the patients remotely. And here is a little overview how we treat them. The treatment is based on anamnesis, the questionnaire, and lab results, and home blood pressure measurements, and of course also individualized lifestyle advice to the patients, and a very close relationship between the doctor and the patient. And we use asynchronic chat messages. So what we are treating is the so-called metabolic syndrome. It's a syndrome consisting of high blood pressure, abnormal blood lipids, type 2 diabetes, and overweight. And these conditions is important because it gives cardiovascular disease like heart attacks and stroke, and also now we are situated here in Baxter in Lund, and these conditions are the main reasons for having chronic kidney disease, of course, also, and chronic renal end-stage renal disease. So this is a global huge task. About 500 million people in the world now have diabetes. Most of them have type 2 diabetes. About 2 billion are overweight, and about 1.2 billion have hypertension and high blood pressure. So you might notice who these three gentlemen are. The picture is from the Jalta conference. It's Churchill, Roosevelt, and Stalin. And actually, they were not very healthy when they took this picture. And they died shortly afterwards, and they all died from stroke, and they all had hypertension. They were not so very much aware of the condition, and the treatment was very bad at that situation. They didn't have good drugs for hypertension. Actually, since it's an asymptomatic condition, mostly asymptomatic, many people, they don't know that they have the disease. And a lot of people with hypertension, they are also badly treated. So it's important to involve, screen for patients with hypertension, and involve patients in the decision to treat elevated blood pressure and to choose the right medication. A little about how it works. After downloading our app, we have made two apps, one for iOS and one for Android, and we have done our own electronic health care record system and our own decision support system. So when the patient downloads the app, the patient answers a few triage questions in order to see if they are suitable for the service. Not all patients could be treated digital only. Then we create an account, and the patient is greeted to the service, and they see a film here in the app, and they also select where to go and take blood samples. We have electronic referrals. Then we send out a blood pressure monitor to them, and they could see an instructional movie to make sure measurements are done correctly. And it's important that they rest 5 minutes before they do the measurements. So we have some nice music and relaxation pictures and so on. The patients could see visualized their blood pressure measurements and also the lab results in a nice way. We have also individualized it according to their risk score. We have done this clinical decision support system, especially for treating hypertension. So all the medical history, the blood pressure data, and lab results, and lifestyle, they are compiled together to individual risk factors and interpretations, and it's presented in a nice way for the doctor, so that the doctor could treat the patients according to guidelines very effectively and fast. We also have a follow-up in a structured and standardized way because we want to know if they have changed their lifestyle, for example. And we have chat communication with the patients. It's CE marked, of course, our medical system consisting of the apps and the electronic healthcare system. We have our own blood pressure monitors that we have designed from a factory, and we have visited the factory and looked at the quality system. We are a young company, but we have done some research. After 1 year, we did our proof of concept study, and we could show that we are treating patients with hypertension more effectively than in the traditional care. The patients were very satisfied with the care, and we had no technical problems. Now we have 18-month data, and here are a subset of patients who were treated 18 months, and they all actually reach the optimal blood pressure after 18 months. Initially, it was only 45% who had optimal blood pressure. It's another picture on that. And does it mean anything? Well, if you reduce your blood pressure only with 10 millimeter systolic blood pressure, you reduce your risk of stroke with 35%, for example, and heart failure by 40%. So this is actually, hypertension is the world's biggest disease and most important disease in the world. So it's very, very important to treat patients effectively. Here's the slide where you can see one patient that we have treated and how the doctor sees it every 3 months. You can see that the blood pressure goes down very nicely. And you can see also the doctor could see a very detailed graph if he or she wants to have it about the blood pressure. You can see if they have measured with symptoms or standing blood pressure, etc. So what is the benefits with the telemedicine or digital care? I would say that when treating patients with chronic diseases, we could give them a better care because we have more data for the patients and we have more continuous care. So the care is better than the traditional physical care. And we also use the doctor's capacity better. We have standardized treatment and we follow guidelines. It's important for us. I would say it's cheaper for the society and it's the same time for the doctor. And it's of course very environmental friendly. And for the patients now during the pandemic, they have no exposure to any contagious illnesses. And it's better access to care. They don't need to travel. It's flexible and it increases the patient's empowerment also. They can see, they get feedback when they measure blood pressure or glucose levels. So they see if the lifestyle changes or the medication is effective. So here's a picture from our team. We have staff working both in Kalmar and in Lund. And here's a little about our development. We have now 14,000 patients we treat with hypertension. And we got on this list, we are proud of that, Global Digital Health, who recognized the health technology companies that had greatest potential to change the way that healthcare is delivered. And because we spell the name with A, we came first on this list actually. So that's all from me. Okay. Thank you very much.
Thank you so much. More earlier than I thought.
Yeah, but I'm fast.
Please stay in the picture. All right, we have some questions here for you. Annette Bornegård asks, who is paying for the service, the patient or the healthcare provider? What does the business model look like?
Yeah, in Sweden we used what we call utomlänsersättning, alltså. So the patient does not at the moment pay anything because the digital care is free. We expected to have a patient avgift for 100 kronor sooner or later, but at the moment it's free. But we will have we got money from their county, 500 kronor for each. The model is not used for us because we are the only company treating patients in this way in Sweden for chronic disease. But we're using the same system as Kry and Min Doctor, but we changed it a little.
Yeah. As we talked about earlier, the reimbursement system is still the problem.
Yeah.
And this is the only way out for these kind of companies. Another question was, what is the main reason for blood pressure to decrease in your studies? Medication or change of lifestyle?
I think it's both, because you have much more data first, and the patients are more aware of their situation, and since they are measuring blood pressure more often, they see immediately if they don't take the drug, the medication, and they can also see if they change something, if they stop eating chips every evening or are losing weight and increase their physical activity. They see it immediately. If you go to the doctor every 6 months, you don't have that effect. It's sort of gamification effect.
It certainly is. Now, from Helena Jeppsson, what is the main reason? No, I got, okay. Who is the one determining if this app is to be used, the patient or the doctor?
The patients are interested and they will register, and then we have this triage. If they are too young or very old, more than 75, or they are pregnant, we can't treat them. Otherwise, we can treat them. So,
in some countries, like in the UK, general practitioners advise people to use these type of solutions.
Yeah. Use of app increased, yes, very much, of course.
Yeah, that was a question from Lisa, if the app has increased during COVID-19.
Yes, it has.
How much? Percentage?
Many 100%. Yes.
Several 100%
Yes.
increase.
Yes.
That's amazing. So the COVID-19 has been the perfect storm for you.
Yeah, I'm embarrassed to say it, but it was good for digitalizing healthcare in the society.
Yeah.
Yes.
Okay. You will stay on for discussions later?
Is that in the afternoon or not? No.
Well, it's 11:45.
Oh, yeah, stay. Yes.
Thank you very much.
Thank you very much.
So, and now the next speaker on this topic, and the last, I think, yes, Mattias Paulsson. Mattias is a serial AI, artificial intelligence, entrepreneur. Since 8 years, he's been focusing on nephrology, cardiology, diabetes, and Alzheimer's disease. He works with clinics and patients and professionals across the globe. Welcome, Mattias.
It's very nice to be here. Thank you. Good. Exciting to talk about predictive analytics in a chronic care setting. Oh, here we have my first slide too. So I'm going to talk about rehumanizing care with predictive analytics. And I'm Mattias Paulsson. As we said, when we talk about rehumanizing care, it's about finding more time for the patients through means that are helpful, like AI tools, for example. And I'm going to go into a case and talk about a little about our experience and how that can be accomplished and the challenges inherent in it. So the proposition is quite simple. There is a specific group of healthcare professionals called care managers or nurse care managers. Not so much in Sweden, but in other countries like the US, who is a little bit of a pioneer in this field. And their sole responsibility is to prevent future hospitalizations and diseases. So diseases generate hospitalizations, which are costly. So what they do is they analyze data and they select patients eligible for preventive care. So typically they would have patients in a certain program that they address with these tools. And then they execute preventive care programs. And the idea and the concept behind predictive analytics is that you can identify these patients automatically and then free up time for the care managers to spend more time on actually delivering the care than preparing the patients. So at face value, this is really a nice concept, but it may not be as easy as it seems. So there are many, many challenges here. The first one is, of course, data access. So in order to do predictive analytics, you need to have a good source of data. You need to know a lot about the patient, and typically you would go into the electronic health records and you would find information there. It helps if the patient is frequently in the hospital, so you get a lot of data. That's why we focused on dialysis clinics, because then you have patients there 3 times a week. But not only the frequency of the data is vital, also the, I would say, the total amount of data. So in our case, we were fortunate enough to also have data from hospitals about their hospitalizations and the cost of the patients and so forth. And then you really have all the building blocks to start making predictive analytics. Data access, of course, as we know, is regulated heavily by GDPR, HIPAA, and other. We deal with patient PHI, protected health information, so it's very, very sensitive data that we have. Also, there is a discussion about the data blind spots. For instance, if we work mostly with dialysis machines and electronic health records, we may know a lot about the patients in terms of their biological and physiological properties, but not so much about the social, and that can have a great impact too. If we compare to, we'll talk about that during causality, I think. The next step is causality. So predictive analytics is kind of a little bit hard because you have a lot of data points. We typically work with anywhere from 50 to 500 parameters that are predictive. And it's hard for us humans to look at 500 parameters and understand how the AI is working. If we compare to something, another application of AI in healthcare, we look at computer vision and image recognition, where you have, for instance, a business case like radiology, where you want to look at a picture and you want to see if the AI can do as good job as a physician, so you also free up time for the physician to be more with patients and explain what is happening, look at alternatives and so forth, more of a coaching role than an analyst role. This is much simpler because you have the computer, the AI system, train on the images, they learn the images, and if you subject them to enough number of images, they will know and they will be able to differentiate between what is a tumor, for instance, and where it's not a tumor. It's a binary outcome. And the technology behind it is solid. You have all the information inherent in the picture that you need. It's a much easier case for the AI. Whereas if we're looking for predictive analytics for chronic care patients, we may not be able to give the data, all the data may not be supplied to the computer, to the AI, and you don't have all the information, and that's what makes it a little bit difficult. And also, how you show the causality. So I'm going to describe a trial that we did in Ohio. We were fortunate enough to have a 2-arm trial. We had 300 patients in the control group and 300 people in the study group. This was a kind of a railway station kind of trial where people would leave and come because we weren't able to keep them in the program. They would move out of state, or they would change program, they would pass away. There were many reasons for them to disappear. And we conducted this trial for about 17 months. So we generated a lot of data. And even though we could see that we were efficient, there were still many question marks around causality. And we had to do a lot of investigation. Were the patients equally ill in the beginning? Were some patients better off? And so forth. There were a little bit skepticism about the Hawthorne effect. So once we provided the nurse care managers and we spread out the patients evenly among them, there was this fear that maybe they would get more enthusiastic about the patients that were actually on the dashboard and provided by the AI list. In the end, we could see that we made money. We made savings in hospitalizations. They weren't the strongest p-value, but they were significant, not highly statistically significant, but almost. And we could also verify it in the claims data. But still, there was a little bit of a fear that we weren't efficient enough. And the way to do it with a two-arm trial, if you think about it, it's really several steps that you take here. So first, you want to identify the patients that are at risk. Then you subject them to some kind of preventive program, and you have the engagement ratio. And then after that, you have the efficacy of the preventive program. So there's a little bit of dilution all the way. But for the patients that you really succeed with, then that is very, very healthy for the community. So we also wanted to isolate how effective were we at making the predictions. And obviously, once you deliver predictions to a nurse care manager or a physician, they will, at least on a subconscious level, start to act on them and try to actually prevent the prediction by itself. So what we did was that we created mirrored groups, patients that looked very similar in their properties in terms of clinics, the care managers and so forth that they had, the neighborhoods, zip codes, everything. And we made predictions on these patients on a daily basis, but no one would ever see these predictions. And then we measured the outcome. So you could say it's like a live prediction and you follow up the predictions. And we had to have something to compare with. And we compared with the random ranking and also with another industry-leading ranking system. And here we could use a lot of statistical tools to evaluate because we had a massive amount of data on all of these patients that we had. And we could show high significance here. But still, it was a little bit skepticism around the use of predictive analytics. And now, of course, just this month, there's been calls for the need of having more stringent practices around trials for AI, because it's easy to lie with statistics, and we all need to know that it's helpful for a society to invest in it. So this actually just came out a couple of weeks ago, and I welcome that very much. It would certainly have helped us. So we talked about data access and causality. We also have teething problems. We worked in the domain of a program, a shared savings program called the ESCO program, the End-Stage Renal Disease Seamless Care Organization. Thank God for abbreviations.